Today. This is our 5th webinar for the Pressure Ulcer Prevention Implementation Sharing Webinars, or in other words, our learning network. And so I thank everyone for joining. We have a really great topic today, and we have a presentation by one of our standing faculty for this project, Dr. Elizabeth Ayello, and I believe Karen Zulkowski will be chiming in a little bit on this presentation as well. And they put a lot of work into pulling this information together for everyone. Just as a reminder, we will be recording this, and we will be making the recording available at the very end. Well, in a couple of days, it'll be available for you to share with your colleagues, and we encourage you to do that. So just real quickly, today's topics, we'll start with just very quickly some housekeeping like we do every webinar, and then a brief update from our team about some of the upcoming webinar topics that we're going to be having in the future. And then our main topic today is going to be on pressure ulcer risk factors, going beyond validated risk assessment tools. And Elizabeth Ayello, as I mentioned, will be presenting on this topic. And let me just note that throughout the presentation, we encourage you to send any questions that you have using the chat or the Q&A feature. Just make sure that you use that little drop-down box to say where you want your, if you're using the chat, who you want that to go to. I would recommend that you do it to all panelists, since we're all in the panelist mode today. But at the very end, if there is time, we'll take some open questions and some, any additional discussion that we want to have. But throughout this webinar today, we actually are going to be doing some polling. And so I want to make sure that you're aware of that feature that will pop up on the right-hand side of your screen when we do the polling. So we are asking you to be interactive in this webinar by completing the poll. All you've got to do is click a button and, to provide your answer. And you'll see that here shortly. So please feel free to use those features. So again, the hand raising, if you want to contribute to the discussion, you're all in mute right now. But when we get to a point where we can take questions, you can use your hand feature to let us know that you have a question. You can also type it in the chat panel. And very importantly, we really want to minimize the background, so please keep yourself on mute and don't put yourself on hold, especially if there's going to be music playing. So mute your phone, use the mute feature. Just an update for the coming webinars. I am happy to say that in January, we have Dr. Mary Litchford, who is going to be providing a presentation on the topic of nutrition. She's an expert in this area, and she's going to be talking about nutrition for pressure ulcer prevention. And then in February through April, we plan to have webinars that will feature presentations from each of the hospitals. You'll be working with your QI specialist to determine what that topic will, or when you're going to be presenting. But what we're looking for is to have the hospital share a little bit about what their implementation efforts have looked like so far, what you're doing, what you've been successful with, maybe what you haven't been so successful with. So these are things you'll work with your QI specialist to determine when it makes sense for you to do your presentation, but that's what we look to do in February and April, through April. And with that, I'm going to turn it over. I'm going to pass the ball to you, Elizabeth, to take over the presentation. And just as a reminder, everyone, we will be doing polling, so keep your eye on the right-hand panel when Elizabeth lets you know that we're doing a poll. All right, Elizabeth, thank you.
Well, thank you, Michelle, and thank you to everyone who is on the call. And I certainly want to thank Michelle and her team, and certainly Karen Zulkowski. We've done a lot of planning for this particular webinar. It's as we all know, in skin and wound care, it's always about a good team. So thank you to everybody. As you can see on my title slide, I'm still the clinical editor and have been for 25 years for the Journal Advances in Skin and Wound Care. and I'm still a faculty member at Excelsior College School of Nursing and a senior advisor to the John A. Harford Institute for Geriatric Nursing. Just want to check, you can all hear me okay?
Yes.
Okay, great. Okay, a little bit more about me. You can see that I'm a board-certified wound and ostomy nurse from the WOCNCB. I currently am the Vice President of the World Council of Ventrostomal Therapists, and actually I'm the editor emeritus for their journal, and Karen Zulkowski, as you might recall, is the current editor. So if you have articles, please send them to Karen. She's always looking for great articles. I write a lot. I consult the CMS. Actually, as the chairperson of the New Jersey Hospital Association Pressure Ulcer Collaborative, where we reduce pressure ulcer incidence by 70% amongst our partners. And I've been involved with the National Pressure Ulcer Advisory Panel since 1999. Actually, my children say, Ma, you know, when are you going to stop going to school and do all this stuff? So I think it's interesting, different people's perspectives. Today I'm taking time to speak to you a little bit about pressure ulcer risk assessment tools, just a little bit about putting into context the Braden scale, where we were, where we are now, looking at pressure ulcer risk factors and using some assessment data for patient care. We wanted to make it active to keep you involved and engaged in this area, so we're going to try this polling. I do polling when I do live presentations by having people hold up strips, but today we're going to be doing it by having you actually click. So every time you see this little diagram here of these people, we will have an opportunity for you to do participation in polling. We have another polling question coming up, and I wanted to get a sense of how many of you are doing risk assessment on your electronic documentation system on your EMR. So you can open up the polling for them, please, and they're going to answer whether it's yes, yes, but not what we want, no, no, but we're in the process of adding information to it, or you do not know. And remember, I don't know who's pressing what answers, and neither does Michelle, so your data will come up as aggregate information, so nobody's going to know what you personally are answering. That's correct, right, Michelle?
That is right.
Okay, so it's anonymous, so no one has to be concerned or worried that everybody else is going to see how I answer. Particularly when we get to some clinical content questions, sometimes people are a little nervous about answering because they don't want people to know what their individual response is. But please be assured that nobody will know what you personally are saying. Okay, so I think this is a pretty good answer that we're getting. Most of you said yes, one yes, but not what we want, and hopefully you're working on it. And somebody is not on electronic systems, and we have 11 people who are not responding, but maybe they're not on. I think that's about the same number. So I think we all know the purpose of risk assessment. We certainly want to identify patients that are going to develop pressure ulcers, particularly since in hospitals there's no financial payment anymore if somebody develops a pressure ulcer in the institution. We want to take a look at this whole area of risk assessment because it's really about making clinical decisions based on a comprehensive assessment of the patient. And I think one of the problems with pressure ulcers is that it's very complicated and it's multifaceted. And I don't think people remember that enough. It's complicated. This is not a 1 + 1 = 2 kind of a situation. There's really a lot of information that has to be gleaned to make a good pressure ulcer risk assessment. And obviously the reason we want to do this is because prevention interventions can be expensive. We want to target it for those who really need it and use what needs to be done to keep costs down. And certainly this will require communication among their workers and across care settings, particularly since now we're all in this 30-day payment bundle that happens now at CMS, so that they want to prevent readmissions to the hospital because of the financial implications to that. All right, so here's the Braden scale. Here's another question here. if you bring this one up, just want to validate how many of you are actually using the Braden scale. So yes, if you're using a modified Braden scale, because some people have modified it, or they just have just the words rather than the full scale, as Dr. Braden has always said that you should use. No would be C. No, but you're in the process and is part of your implementation plan. And E, of course, is I don't know. And remember, I don't know what you're doing. Okay, so this is very good. We have 12 people that are basically answering online, so that's great. As soon as we get 12, we know we can move on. And I'll be interested. The person who's using the modified Braden scale, maybe when we get to the end and more open discussion, you could tell us a little bit about how you've modified it and what you think of it. A couple of years ago, Sharon Baranowski and I have been doing a survey of generalist nurses, and as much as all of us think we know what the Braden scale is and that all nurses know about it, we asked this question, as you can see here, whether people could answer this correctly. If the Braden scale is used to assess the patient's potential to develop a vascular ulcer. And over the 2 times that we've done this, the good news is that we're moving in the right direction. More people know that the Braden scale is not to assess for a vascular ulcer, but what this points out to me is at least a little bit over a third of nurses out there really don't know what the Braden scale is used for. And in some data that Karen Zulkowski and myself and another team that we are putting together to get it published, not everybody in nursing school is even taught about the Braden scale and pressure ulcer risk assessment. So we've got a lot of work to be doing here with new nurses and new graduates. So I think it's time to really rethink risk assessment. And when I've talked to nurses and do consultations in hospitals around the United States and actually around the world, what is clear to me is that nurses really think that this is just a task that they have to do. I have to fill out the form, whether it's electronically on paper, and just get it done. But they don't always complete the scale correctly. I think math is a challenge to some nurses. They don't even add up the 6 subscale numbers correctly, which is always an issue if there's litigation. That's the first thing the lawyer says is, look, how could they take care of patients when they couldn't even add up the 6 numbers correctly? There's a phenomenon which I have labeled as copy forward, which means that whatever the numbers are on the first time somebody does the Braden scale, people just continually copy the same numbers and really don't do the risk assessment of the patient. It's kind of like in my day, everybody had respirations of 20. Well, what I'm seeing a lot of is that people just give an eyeball number and every patient has a Braden scale of 20. So that's, doesn't always match. The numbers don't always match what's going on with the patient. And then, to me, what I think is a tragedy is that if they do the Braden scale, they don't even consider it when developing the plan of care. They just pick interventions, but don't look at what's going on the subscales and the total Braden scale number. But I think one of the most frightening parts to me is that people are not thinking about what they're doing, and they've lost this critical thinking piece. And I recently came across an interesting paper, a white paper, on new nurse preparedness. And I want to just say in full disclosure, I am not in any way being disparaging to new nurses. I have a daughter who just graduated nursing school and just started her first job in a hospital. So I'm very, very sensitive to this issue. But in this survey that was done, and you can actually go online and read the whole survey if you want at www.nursegapsurvey.com. But I think that it was identified that critical thinking, and this was not specifically on wound care, but just in general, that this was a huge weakness amongst new nurses. And you can see the numbers, 85% in practice that were asked, and 49% of educators thought that this was a real area we need to think about. So we have to help nurses think about why they're doing risk assessments. Now, this is the information that's from the NPUIP, European Pressure Ulcer Advisory Panel, and the Pan-Pacific Pressure Ulcer Injury area about what they should be doing. And I think most of us understand this and know this, that you need to do a risk assessment. But they say under this recommendation, which, remember, strength of recommendation is pretty strong here. They give it 2 thumbs up. Caution us to not just rely on the total risk assessment score alone for the basis of risk prevention, that you really need to look at the risk factors to guide your risk planning in the subscores also with the patient. So I always like to say people are more than numbers, because you need to think about that regardless of what the subscore scores are, and if they're low, you need to incorporate them. And low means a 1 or a 2. So if somebody has a 1 or 2, let's say on moisture, you need to incorporate that into your prevention plan of care for pressure ulcers. And that's regardless of whether the Braden scale is 18 or below. So if somebody had a 19, but they had a 1 or 2, let's say in nutrition, or 1 or 2 in moisture, you need to plan that for prevention. And then I think the other area that we sometimes have difficulty with is looking at what's actually happening. So that, you know, let's say a patient has the ability to walk. So maybe you gave them a high score on the activity area of the Braden scale. So on paper it looks great. I mean, you know, they can walk. But the reality is that the patient is not walking. They're just sitting all day in the room. So really, you need to target activity for that particular patient in terms of what's going on with them. This slide you have seen before, and what we had done, and this is the work that Karen Zulkowski and I have done, and it's in the AHRQ toolkit, so that if you want to go back and revisit, because we did a whole webinar on this, and we're not going to be talking about that in detail today, is go to the training webinar number 5 and look at, because we broke out interventions by the subscale scores, so hopefully that will help you. Because we really wanted to go beyond what was in the Braden scale. And I don't know if it's because I like history or I'm just getting old, and reminiscing is a good thing to do as you get older. But I actually went back and reread all the original research that Dr. Nancy Bergstrom and Barbara Braden did when they introduced the tool. And it's always good to look to where things were as we look forward. So remember, it was initially developed as a tool for measuring in a research project. It was not originally designed as a clinical tool. And that the original population that they tested was from nursing homes. It was long-term care facilities. So if you look at the original articles from 1987, which they published in Nursing Research and Rehabilitation journals, it really was about what factors they thought could be included in their study, which actually was a study on nutrition. And I've had conversations with Barbara Braden over the years about, you know, how it was created and why it was created. And I think it's good to remember that. And that they really, Barbara Braden didn't like the existing pressure ulcer risk assessment scales that were available at the time. And I'm sure you're familiar with probably the Norton, which is one of the oldest ones. And there was also a scale called the Gosnell scale because of the way that they looked at the internal and external factors. So she actually did a logistics study, and this is the original schema that Dr. Braden came up with for the etiology of pressure ulcers for the Braden scale. And I think it's always good to revisit things. The pressure areas, subscales, were mobility, activity, and sensory perception. But if we look at tissue tolerance, in terms of the regression analysis that she did at the time, moisture, friction, and shear came out, and that's why they wound up on the scale, and nutrition. But other factors, as you see listed here, like age, arterial pressure, and other hypothetical factors that Dr. Braden looked at, but there just wasn't enough evidence at that time, including blood flow, the role that stress played on patients. I thought it was interesting. They even looked at smoking in terms of, probably because its impact on the cardiovascular system, and skin temperature. So even originally in the conception of the Braden scale, Dr. Braden was looking at that there's a whole host of risk factors out there that may impact on the patient's condition at that period of time, but because of the lack of good research that was out there, none of them factored out in the analysis. And they actually called for, in most of their studies, that we needed more studies, and hopefully they wanted them to be prospective rather than retrospective, to really look at what factors intrinsically would affect the tolerance of tissue from pressure. And I think that's why I'm going to spend a lot of time talking about some studies that have come out since 1987 that we might want to be looking at. So you saw this slide in terms of the earlier seminar that I did, a webinar, number 5, in terms of lots of factors that nurses and other healthcare professionals are looking at. Karen did a great job on skin assessment in one of the webinars. Certainly medical devices, which have operated in the 1980s, what's going on in oxygenation and perfusion, medications, comorbidities, and all of these we mull around in our brains, if we will, plus the Braden scale, to come up with a clinical decision: is my patient at risk for developing a pressure ulcer? I thought that we would look at some of the evidence that's out there in terms of internal and external factors. Since this original schema of the Braden scale was developed, because I think as nurses we are looking at these factors because some of us have said, well, this doesn't really give me the 6 subscales on the Braden scale, may not be giving me the best picture of my patient. I think that's what we're all doing. We're looking at how does my patient present so that I can make a decision to whether or not they are at risk for a pressure ulcer. So we're going to go forward now to look at and see what's out there. So one of the questions which Karen and I get a lot is, what do we think about? When we go in to assess a patient, what's going on in our minds? So what we tried to do was to put down on paper this risk factor checklist. Now, I want to be absolutely positively clear. This is not in any way, shape, or sense of the word a pressure ulcer risk assessment tool. What this is putting on paper, making visible our thinking of what Karen and I think about, and it probably also includes things that other colleagues out there are thinking about on a piece of paper for people. Because people say, well, what about? So we put it down on this paper for you, and to use it, if you will, as a framework for me just to organize this webinar to keep me on track. Now, I'm not, because of time constraints, going to be able to talk about everything on here. But I did want to highlight some of the research in certain areas that I thought would be helpful for you. So one of the first things has to do with age. And actually, in some of the data that actually Dr. Braden has published, they looked at older people, and I don't know, I look at this and say over 65. Some of us may argue with that particular number, but that in the studies that if you were older, there was an increased risk of developing pressure ulcers. However, in the recent clinical guideline, they did not always support that to the extent that it's as clear cut. I want to emphasize that having a check on this mental checklist, if you will, doesn't automatically put somebody at risk, but what it does is alert you to look at the full picture of the patient and say, is this, because my patient has a Braden scale scores plus this, make this person at risk for a pressure ulcer, okay? History of pressure ulcers in a location. I put a visual on here. This is a heel, which, as we all know, the number of people developing pressure ulcers on the heel has certainly increased over the years. And part of that is because of the vulnerability of the heel. It doesn't have a really great blood supply. It doesn't have a whole lot of tissue between the calcaneus bone, so that it's very easy for that tissue to not to be able to tolerate pressure. The other thing has to do with the angle and position of the heel, so it's not in dorsiflexion, as well as preventing external rotation of the heel, because there's even less tissue when the heel is externally rotated, and you have the bone of the calcaneus really digging into the bed at that point. So here's somebody who comes in. Certainly the skin looks a little bit dry on that heel, but you want to know the history, because this person on admission, actually, you were looking at a healed heel pressure ulcer. This is what that heel looked like 6 months prior to admission to that institution. So knowing that is very important, because you need to protect those heels regardless of whatever the scoring is on the Braden scale, because that tissue strength is not at 100% anymore because you had a healed pressure ulcer. And certainly you want to look at concurrent pressure ulcers, and some data that Courtney Leiter published in an article in the WCET journal several years ago. He found that if you had a pressure ulcer on one heel, you were 30% more likely to develop a pressure ulcer on the bilaterally on the other heel. So again, it's a risk factor. Over the last couple of years, we've seen a lot of information about medical devices in use, and I'm sure all of you are familiar with the National Pressure Ulcer NPUAP's position statements, which you can download for free from their website, as well as a one-page enabler with nice photos to help raise awareness to staff about pressure ulcers in ICU, in the OR, pediatrics, et cetera. So they did a really nice job of doing that. So people need to be aware that medical devices cause pressure ulcers. And in this year alone, there's an article in the JWCN by Pittman et al., which showed that they were able to decrease their hospital-acquired pressure ulcer rates for medical devices by just raising awareness that device-related pressure ulcers can cause pressure ulcers. And you can see here, people sometimes forget how tight straps are on an oxygen mask, so certainly looking below that is important. So here's a slide which shows some of the conditions. This is not all-inclusive, and this is from the NPUAP guideline on page 119. So lots of devices, lots of areas to be looked like, certainly to make sure tubings are not laying on the skin. And of course, remember that if a medical device is on the mucosa, you cannot stage it, and that's a different NPUAP statement than about the medical device-related pressure ulcer statement. So here's a polling question. I want to keep you involved in this discussion, so if you could put the next question up for them to poll. So how often should clinicians be assessing the skin beneath a medical device? So how often should they be assessing the skin? Should it be daily? Should it be twice a day? Should it be 3 times a day? Or I do not know. And again, remember, we don't know who's saying what, who's voting what. So please do, answer, guess if you want, or say I don't know, but I think it's interesting to see where we are with this and what people are really doing. Okay, so the interesting thing here is we're all over the map in terms of how often we're doing that. So here's the guidelines from the NPUAP, which they say, page 119, that they, besides considering adults as well as children to be at risk for pressure ulcers from medical devices, that you should be inspecting the skin at least twice. So those who picked B, good for you. And those who picked 3 times a day, good for you, because greater than twice daily if there are individual conditions such as fluid shifts or edema. So those of you who are doing it twice and 3 times a day, you are spot on with the NPUAP guidelines. And for those of you who picked daily, you might want to consider changing your policies and procedures in your institutions to be in line with the 2014 guidelines. Okay, another area that we looked at were some intrinsic factors. And remember, medical devices are external factors. We can have control over them in terms of making sure people aren't laying on them. Intrinsic factors may or may not be modifiable depending upon what's going on with the patient. Certainly, if the patient has diabetes, we want to seek to control it as best as possible, as well as vascular disease. So I'm going to talk about a few of these. I am not going to talk about malnutrition since we have Mary Litchford coming in January, and she can do a really great job of doing that. So let's look at some of the research on some of the patient diagnoses. And remember again, in Braden's original schema, she said we needed to look at what's going on, what comorbidities was happening with the patient. All right? So this is a study that I was involved with my colleagues at NYU Medical Center. And we took a look at medical records over a large period because we were very concerned about the number of heel pressure ulcers that were developing in our patients. So what we did is we matched the patients for their age with a group of patients without heel pressure ulcers because we wanted to look at what was going on, what was the condition of these patients. So this is a retrospective review of our patient data, and because we're on electronic medical record there, we were able to do that. And, we had a lot of hunches. It was a lot of fun for us, and I'll show you on the next slide from the literature and from our clinical experiences the different factors that we thought might account for comorbidities or patient conditions that would attribute to heel pressure ulcers. And what we did was, after we put in all this data initially to compare patients with pressure ulcers on the heel as opposed to those who did not, we did logistic regression modeling, which, unless you're really into statistics, and I'm not a statistical expert, you come out with the factors that will independently predict heel pressure ulcers. And when we got those factors, then we did a validation analysis by looking at a different set of data to see if they were predictive or not. So here's the list of areas that we thought that we looked at in terms of looking at differences between people who had heel pressure ulcers and who didn't. And I'm sure as you look at this list, diabetes, vascular disease, neuropathy, advanced age, perfusion problems, people at different ends of the weight scale, people who have high BMIs and people who have low BMIs, surgical procedures, immobility, ventilator days greater than 3, their activity status, and longer than 3 days ICU stays. There might be others that you thought about or are important to you in your institution, but this we gleaned from our list and from the literature. So when we did the main results, and that was based on 307 patients, this is the hardcore data that came up in terms of predictor variables: diabetes mellitus, vascular disease, immobility, and Braden scale scores less than 18 or less. And I wanted to give you the full data for those who like to have the full data, and this is, as you can see, published in the JWCN journal. So we then took those factors and validated it in another population, and they held up. So that we now at NYU start to look at Braden score scales plus diabetes mellitus, vascular disease, and immobility as important factors to look at to prevent heel pressure ulcers in our patient population. Now, interestingly enough, when our findings collaborated with data that Courtney Leiter had published in 2012 in terms of people with cardiovascular disease and diabetes mellitus, where he found, and he looked at over 50,000 records of hospitalized people on Medicare in the United States, that these were predictors of hospitalized persons over 65 in the U.S. who develop pressure ulcers during their hospitalization. So again, I think this is good evidence that we need to start looking at certain diagnoses for pressure ulcer risk. So what else in terms of intrinsic factors for us to be looking at? So paralysis is one area that we need to look at, and actually part of this is captured in the Braden scale on sensory perception. And here's some examples to help people, because not everybody thinks about what paralysis is. So spinal cord injuries, cerebral vascular accident, traumatic brain injuries, and I'm sure you could add to that list. So here's another question that I would like you to answer, and as it comes up. So what happens to tissue tolerance? Because remember, these are those intrinsic factors when somebody is paralyzed. Does the bone shape change? Do the ischial tips get flatter? Or do you not know? So if you would please sign in. I only gave you 3 choices on this one. So if you could do that and take a look at that, because we do know that people with paralysis are more prone to developing pressure ulcers. So let's take a look at that and see what happens to them. So how are you doing with the voting? Okay, well, I love honesty. Thank you for the 6 of you who do not know. And those of you who pick bone shape changes and ischial tips are flatter, you are correct. So the longer somebody is paralyzed, there actually is physiological changes that go on in the bones, okay? The ischial tuberosities that people would sit on, for instance, in a wheelchair, actually get flatter, as well as there's a loss of gluteal mass and there's more fat tissue that infiltrates into the tissue. So all this translates into a change in tolerance, and the longer somebody is paralyzed, the more changes go on in the tissue and the bones in that area. So just because somebody has been paralyzed for a long period of time, don't think they're immune to getting a pressure ulcer. So we need to think about that. We need to think about that, particularly about pressure redistribution. If there's a support surface on, for instance, a wheelchair, just because it's been there doesn't mean it's still doing its job. Everything has a life expectancy, including support surfaces. All right, so what about some physiological variables? And again, I'm only going to talk about a few of them. This is a study done by Helena Shanks down in a hospital in Florida where they were implementing their skin bundle. And they were concerned because even though the nurses were really doing the turning, repositioning, looking at skin care, and doing what was in their bundle and nutrition, they were still getting people that the skin was failing, they were getting pressure ulcers. So their findings, they looked at that the people who got pressure ulcers, that their 26% had O2 sats of 92% or less, and almost, as you can see, 43%, a large proportion of them had numbers of hypotensive episodes. So they started to look at that as predictors for pressure ulcers as risk factors in their critical care area, and once they did that, they were able to decrease pressure ulcers. So the NPOAP guidelines, they talk about perfusion and oxygenation. So we need to know a lot more about this area. There's not as much research as we'd like to see, but start to think about that for those of you with critical care patients. And in Courtney Leiter's research, which I talked about earlier, he also found that there was a higher rate of pressure ulcers in hospitalized patients who were on corticosteroids. So again, look at the medication profile and how that might be affecting the skin and the skin's ability to tolerate pressure. And what about transfers? Okay, as we move patients around, as we move them up in bed, as we do micro shifts, for example. So here's some research that was published by Jeremy Honecker and his colleagues that looked at situational awareness, as I call it, precipitating events. Look at the number of people that developed a deep tissue injury, and the precipitating event was transfer, 78.8%, tissue perfusions, surgery. I was amazed to see falls with such a low area, but that might be specific to his particular data in his patient population. Notice the range of days before the precipitating event being 1 to 5 days, with the average being just a little over 2.5 days. And what he called meaningful physiological variables in terms of anticoagulation, again, medications. We need to be looking at medication profiles and anemia and hemoglobin A1C for patients with diabetes. What about surgery? We cannot not institute surgery. They need to go to the operating room. They need to go to the operating room. And quite honestly, as many of us have said, the Braden scale doesn't really work when a patient's on the OR table because nobody's talking, nobody's eating, nobody's moving, etc. So taking a look at the literature, one of the things that we have found is that the length of surgery being greater than 4 hours and being in a prone position, particularly medical device injuries that happen in the OR for surgical patients. And here's the NPOAP statements where they say, look at the length of surgery, the number of hypotensive episodes. They do talk about core temperatures and reduced mobility on day 1 postoperatively. Here's some data for you, again, which I did with my colleagues at NYU, which is published in the WOCN journal. Again, you can't not send people to the OR. So we decided to use as a risk factor people who were in the OR 4 hours or longer. Any skin assessment changed, so the skin looked different. So we put on their wristband. We just wrote it as an awareness, so people would be implementing risk assessment plans, because quite honestly, people don't look at the operative report when they're in other areas outside the OR. But by physically writing it on the armband and putting a colored armband on the patient, it was an awareness to look at them. And here's our results. It took 3 years, but we decreased hospital-acquired pressure ulcers from 7.3% to 1.3% just by adding that risk factor of 4 hours or more in the OR, prone position, and the wristband to alert people we need to be thinking pressure ulcer risk with these surgical patients. Here's another study that was published by a different group of people looking specifically of people with head and neck surgeries, and they implemented fluid pressure ulcer reducing OR pads, and everybody had standard OR thermoregulation using convection warmer. So you see the incidence pre and post, they were able to eliminate pressure ulcers. So again, we need to think about specific areas for our patients in the surgical area. And what about, again, these extrinsic factors, which we may or may not be able to modify, but we need to be aware of. And I think that is, from my point of view, a very important factor. Now, what happened to this patient before they wound up on our nursing unit, whatever it is, whether it's the emergency room or ICU, our OR, or our postoperative patient? So I have asked Karen if she would chime in here, because we have the ability to have the author of this study really talk about the next couple of slides. So Karen, would you go through the next couple of slides, and then I'll pick back up again when we get to the polling questions after this.
Okay, thank you. A number of years ago, I was working with an ICU at Billings Clinic, and we were looking at people that came in and what was happening in terms of skin assessments and then what they truly had. So in the study period, there were 1,746 patients admitted to the ICU. And of those, 152 patients, or 9% of them, had some skin problems. And what the admitting nurse did was just simply checked on a form that, yes, there were problems. And then we went back and actually looked at the patients themselves and determined exactly what it was. But of the persons that had skin problems, of those 152 people, 27 patients, or 18% of those, were actually pressure ulcers. And 17 patients, the nurses had indicated, had the potential for pressure ulcers on admission. The diagnosis for these people was respiratory issues, neurological issues, cardiac, sepsis, and renal issues. And if you think about it, that's pretty much the majority of the patients that are coming to ICU have some of these problems. Next slide. So in this study, we actually went back then and looked at what happened to these patients before they got there. The study was done in Montana, and even here in Hawaii, there can be really long transportation times. So
Karen, I want to tell you that when I once had a colleague from the Midwest here in New York City, she was amazed that it took us an hour to go 6 blocks in traffic in New York City. So it can vary.
Yeah, it was like in Montana, they would transport you to the local hospital, which would take in 25 minutes from where I lived. And then it would have been another hour to Billings for if you needed emergency surgery or anything. So what we found was people who came in with a pressure ulcer had 65 minutes in ambulance. In other words, if the total was about an hour for both of those, then it would have been significant. And the people that were on a backboard at long times, transportation times of about 51 minutes. Okay, Elizabeth.
You still there, Karen? Karen? Am I still online?
Yes, you are. I think we've lost Karen's audio.
Okay, I'll keep talking then, and if she comes back in. Here you can see some of the additional data which they gleaned in terms of what was going on with the patients in her study with her group on admission. You can see that the Braden scale scores, the range was 9 to 21, and the mean was 14 for them. And once again, you can see the range of serum albumin.
Sorry, I disappeared there. I dropped the whole call.
Yeah, that's okay. I went through the additional data that's on the slide here. So if you want to pick up on what you found in terms of the stages of people who had pressure ulcers on admission, Karen?
Yes, and big thing here is, you know, they found all stages, but the big thing that was so significant was that of those people that came in, that the nurses had first checked what they thought it was back and relooked at. 31%, or 47 of those patients, were either not identified correctly as having a pressure ulcer or not staged correctly by the admitting nurse. So they identified they had a skin problem, but they didn't identify it correctly or they didn't stage it correctly. And that was pretty significant. The mean age was 59, which is a lot younger than you think. 3 of the patients had been transferred from the smaller critical access hospitals. And the length of time in these smaller hospitals was 2 to 6.5 hours, with 15 to 60 minutes transportation time. One patient, the transportation time was actually greater than 90 minutes prior to the ICU admission, and one had an 8-hour ER stay prior to it. All the patients had activity limitations prior to admission to the ICU, so these people had probably been sitting around in their recliner, having problems breathing, not moving very much to start with. And like I said, the Braden risk score was 9 to 15, so some of them would have shown really high risk, some of them would have been risk, but not quite as bad. The serum albumin was very low in all these patients, and it ranged as 1.2 to 3.7, and as we know, 3.5 is the cutoff. So they were all at risk nutritionally, and it was probably going to get worse following whatever the surgery was or the fact that they hadn't eaten then for a number of days. Next slide.
So certainly looking at transportation times is something that people need to start thinking about when people come into the emergency room and what they were on and trying to find out that information for risk.
And you've all heard me talking about it in the root cause analysis where I kept saying go back and look at what happened, go back and look what happened. The patient might have developed the pressure ulcer seriously on the way to the hospital or from the nursing home to the ER because they were stuck in traffic. You know, it was a non-emergent transport.
Okay, I have another question for our participants. So do you have automatic triggers in your electronic health record for lower Braden subscale scores? So if you could indicate either yes, no, but we're working to add them, or I do not know. And I know that one respondent does not have electronics, so you could probably, you're going to probably be picking no. And there is evidence out in the literature. There's some articles that were published a couple of years ago in the JWOCN journal that adding automatic triggers, for instance, you know, that if you automatically have a low score in activity or mobility, it automatically triggers a consult. Okay, great. Okay, so 5 of you yes, 2 no, and 3 of you are working on them. That's excellent. That the more you automate things, again, it helps with that thinking and triggers people to say, okay, we need to do this, we need to do this, think about this. All right, do you have automatic triggers in your electronic health record for factors outside the Braden scale, which is what we've been talking about here in terms of some of the factors that we've been looking at, like transportation time, diagnosis, medications. So if you would select comorbidities, you know, do you have anything that triggers that? And I think that one of the problems and why critical thinking is so difficult is that we have a lot of information that's fragmented in the healthcare record, but technology gives us the potential that we can then take pieces of information like age, like paralysis, like comorbidities, like lab values, and interpret it to say, think about this person could be at risk for a pressure ulcer. how are we doing with the voting here? I'll be very curious to see what this. Okay, all right. So something to think about. Something to think about that maybe technology could do that for you, so that if somebody has low serum albumins, does it automatically trigger a nutritional consult, for example, for you? Or somebody is paralyzed, automatically OT or PT comes to evaluate seating surfaces for that person. So we've talked a lot. I wanted to leave 5 minutes, and according to my clock, we have about 6 minutes. So in summary, always look at the whole person. They're more than numbers. Again, I want to emphasize that the risk factors that we put together on that little checklist for you is not a tool. It's just a visual representation of factors and things that we think about, gleaned from the literature that have found that when they are present, people have a higher risk of pressure ulcers. And as I said, I think one of the problems that makes it complicated is they're not all neatly in one place, and they're scattered throughout the medical record, so that if I was a techie person, I would want to make it so that that information, if it's in the medical record, then spits out an information or a message to me to say, consider that this person could be at risk for a pressure ulcer. So we've talked about pressure ulcer risk factors. Hopefully we've given you some new evidence that goes beyond the validated tools for you to think about and see if they're applicable for your patients in your particular facility, because that's where it really makes the difference. And I think we're at the last slide in terms of comments and questions.
Thank you so much, Elizabeth, and Karen, too. We have just a minute or two. If anybody has any particular questions that they want to ask, we welcome you to ask those questions. I think most people have been unmuted. Or you're, again, welcome to chat those or send your questions.
The other thing we can do if we run out of time is people could send you the questions and take a look.
Absolutely. Absolutely. We welcome your questions. We send them off to our standing faculty and ask them for their input and insight. So are there any questions at this point?
Well, we said a lot. We did. Covered a lot of grounds. And I know it's getting late, so one of the things I do want to say is to wish everybody very happy holidays.
So maybe you could just advance to the next slide then.
Sure, and also to remind people about the next session in January, where Mary Litchford is going to be talking about nutrition for pressure ulcer prevention. And as I said, we really didn't dwell a lot on that because I knew you would have a whole session on that. And I certainly want to thank Karen again for coming in and just talking specifically to her research. It's always nice to hear from the actual researcher.
Right. Well, I just want to take a moment here just to say thank you very much. You put in a lot of time and effort in developing this presentation. And Karen, thank you also for contributing to all the thinking that went into this. I think we heard a lot here, and I hope you will go on and potentially, take that research and maybe what we need is a new instrument, something that goes a little beyond what we already have. A lot of new information out there since the original Braden scale was released. So thanks for sharing all this information with us, and I hope that everyone got something useful out of this. So just a reminder, please complete your webinar evaluation survey. That helps us very much as we plan for the future webinars. So with that, I think we are done and everybody is adjourned.
Thank you so much.
Thank you.
Bye.
Bye.